Welcome to this video on T-wave abnormalities, a systematic guide to ECG pattern recognition designed for emergency medicine residents. In this session, we will cover how to classify T-wave patterns, recognize OMI equivalents, interpret Wellens syndrome, and distinguish ischemic changes from mimics. Why do T-waves matter? They are often the most subtle and earliest clues to time-critical diagnoses like occlusion myocardial infarction or life-threatening hyperkalemia. A normal T-wave reflects ventricular repolarization. It is typically asymmetric with a slow upstroke and faster downstroke, generally following the polarity of the QRS complex. When defining an abnormality, look for T-wave inversion in upright leads or a loss of normal progression. However, always be mindful of benign variants, like the juvenile T-wave pattern. Our classification framework organizes T-wave abnormalities into four main categories: peaked or hyperacute, inverted, biphasic, and flattened or nonspecific patterns. Peaked T-waves are a classic hallmark of hyperkalemia. They are often tall, tented, and narrow-based, with an amplitude that appears disproportionate to the QRS complex. In the context of ischemia, hyperacute T-waves are the earliest sign of an occlusion MI. They are typically broad-based and ample, preceding formal ST segment elevation criteria. The De Winter pattern is a STEMI equivalent. Look for upsloping ST depression at the J-point that transitions into tall, symmetric, peaked T-waves across the precordial leads. T-wave inversion has both ischemic and non-ischemic causes. Our diagnostic framework helps you differentiate acute coronary syndromes from other findings, like strain patterns or CNS events. Wellens syndrome is categorized into two types: type A, which is biphasic, and type B, which shows deeply symmetric T-wave inversion in the precordial leads. Clinically, Wellens syndrome implies critical LAD stenosis. Remember that the patient is often pain-free during the observation of these ECG changes, but they require urgent intervention. Non-ischemic inversions include LVH strain, which often presents with a reverse checkmark shape, and secondary repolarization changes seen in bundle branch blocks. Cerebral T-waves are deep, wide, and sometimes bizarre inversions. These are associated with intracranial pathologies and reflect a neurogenic rather than primary coronary mechanism. Finally, in pulmonary embolism, T-wave inversion in the anterior leads can reflect right ventricular strain. Always correlate findings with the patient's clinical presentation. Cardiac memory occurs after periods of altered ventricular activation, such as pacing or tachycardia. It manifests as T-wave inversion that persists in previously depolarized leads, even after normal rhythm returns. It is crucial to distinguish expected drug effects from toxicity. Digoxin therapy typically produces a characteristic scooped ST segment depression, often called the Salvador Dali mustache, which is not in itself a sign of toxicity. Pericarditis typically follows a four-stage evolution. Early stages show diffuse concave upward ST elevation, which later progresses to T-wave flattening and eventually deep, diffuse T-wave inversion before returning to normal. Biphasic and flattened T-waves require careful context. While they can indicate conditions like Wellens syndrome or hypokalemia, they are often nonspecific and should always be compared to prior tracings when available. Adopt a systematic bedside approach. Always start with the clinical context, describe the T-wave morphology and distribution, compare against previous ECGs, and use serial tracings to guide your disposition. Avoid anchoring on benign variants, especially in high-risk patients. Remember that a single snapshot can be misleading. Trend your findings to rule out evolving emergencies like STEMI or hyperkalemia. For deeper study, consult current clinical guidelines from the American College of Cardiology and European Society of Cardiology regarding acute coronary syndromes and pulmonary embolism management. To summarize, always categorize the pattern. Identify reperfusion pathway triggers, distinguish ischemic from non-ischemic causes, and prioritize serial assessment over a single reading for patient safety.